Hi, everyone. I am Diana Yan. I'm one of the pediatric emergency medicine physicians at Mount Sinai Morningside in New York City, and I'm excited to be moderating the session entitled Simulation in Community EDs, Faculty and Staff Development. I'm first going to introduce each panelist separately, and then we're going to have the panelists talk about how they initially became involved in simulation within the community setting in particular. Our first panelist is Dr. Jessica Shane. She is an assistant professor of emergency medicine at Mayo Clinic, Rochester. She is the director of Mayo Clinic's EM Community Simulation Program. She works at both Mayo Clinic and in the community EDs within the Mayo Health System in the Northeast Minnesota region. She has a particular interest in situ sim, process development, as well as systems integration. Our next panelist is Dr. Barbara Walsh. She is a clinical professor of pediatrics and emergency medicine at Boston University Chibosian and Evidison School of Medicine. She is the director of mobile outreach and in situ simulation, as well as the associate director of the Simulation Center at Boston Medical Center, where she directs all of the in situ simulation and education for interdisciplinary providers. In particular, she founded and directs the COMET program, which stands for Community Outreach Mobile Education Training, which is a comprehensive in situ high fidelity simulation program for interprofessional teams to participate in high risk, low frequency resuscitation events so that they can work on teamwork, communication, as well as systems issues. It is a patient quality as well as a safety initiative that spans to any unit of practice as well as any discipline within medicine. Our third panelist is Dr. Lisa Lincoln. She is an assistant professor of emergency medicine at the University of Rochester School of Medicine and Dentistry. She is an assistant director of emergency medicine simulation and is in charge of running simulations at one of their community sites called Highland Hospital. She has a particular interest in preparedness for high acuity, low occurrence events at resource limited sites, and also in incorporating stress reduction and mindfulness techniques into simulation training. And then last but not least is Dr. Annie Runkle. She is an assistant professor of emergency medicine and pediatrics at Nationwide Children's Hospital and the Ohio State University College of Medicine. At OSU, she has worked to develop regular low fidelity pediatric simulations in their community ED satellite site. She is also the associate director for Ohio Emergency Medical Services for Children's Program, so EMSC. And she has a particular interest in pediatric readiness in the community and rural EDs, and also in the role of low fidelity simulation for both pediatric competency as well as for latent threat detection. So those are our four highly esteemed panelists, and we are going to first start with each of them talking about a little bit about their community sites and then how they got involved in the work that they're doing there. How about Dr. Walsh will go first?
Oh, gosh. Okay. Hello, everybody. Thanks for joining. So my journey started eons ago. I've been doing sim for well over 2 decades before it got big and sexy and cool. I started doing in situ simulation on my pediatric floor in PZD with an American Girl doll way back in the day. And then it grew from there. And so the way I got involved with in situ community simulation was where I was practicing at the time was UMass Medical Center in the Central Mass area. And a lot of our community partners would call for transfers. And I would say, okay, this kid sounds sick, do A, B, and C. And then that will optimize care until they get to me. And often when they came, A, B, and C never happened. And so it became a curiosity and a question of, I wonder what's going on. Are they not comfortable? Are they not confident? Do they not trust me? Are they just unable to follow through? And so that's when I took the simulator on the road. That was about 2009. 2008, 2009, I actually went to a bunch of community sites and did a little pilot study at 7 different hospitals as well as inpatient units, ran them through some high fidelity critical situations and really looked at what's your confidence, what's your comfort level, and no surprise as the complexity, invasive procedures, acuity got higher. All practitioners of any background, RT, nursing, physicians, etc., none of them were comfortable and were confident in taking care of a critically ill kid. And so Comet was established from there. I've done research with it with impacts, but basically Comet started as a pediatric emergency medicine in situ training program where I would go out to the community partners and run in situ simulations. And it evolved over the past decade or so into a patient quality and safety initiative. Initially started as a peds emergency medicine program in EDs, EMS sites, community health centers. And then the vision was a lot bigger about really best practices anywhere you go. And so no matter where you go, you should be getting the best care that you can. And so we do programming of all types. We've grown it into a faculty educator list of about over 20. We go to EDs, PACUs, ORs, labor and delivery floors. We run any kind of program in any site, and it's all custom tailored. We do Boston Public Schools. We do a trauma program for them because of all the penetrating trauma they're seeing. We have done different EMS grants with MCIs and involving hurt. Pretty much it's a boutique program. You come to us, you tell us what your gap or need is, and then we create a program around your site. We bring the mannequins, we bring the specialists, we bring the SimTechs all to you, and we run programs in your setting, looking at systems issues, safety threats, etc. We videotape, we take pictures, we take notes, and then we report out of our findings and then give an action item report of what changes to make, opportunities for improvement, that kind of thing. And I've been doing it now over 15 years. And it's a lot of fun, but it's a lot of work. So I'm not just at like one site, we travel all over the country.
That's really cool. I love how you started with an American Dream doll.
I
It's
did.
like,
And the
yeah.
American Girl doll is in great shape, and the simulators, as we all know, are horrible. Just saying. Simulate my American Girl doll for my daughter's kids when she has them is in great shape.
All right. Thank you for that. Let's go with the next person on my screen, Dr. Lincoln.
I work at the University of Rochester, and for my first 2 years out of residency, I split my time between the academic medical center and one of the community sites. And then I really loved the community site. For the past 10 years, clinically, I work exclusively at one of the community sites affiliated with the academic medical center. And what I learned working there was that it was a little bit of a luxury working at the academic site, that when someone would come in who was critically ill or needed something, there was a specific area of the emergency department where they would go. So you would shunt the patient there, there'd be experienced nurses. And it was a whole different thing than working at a community site where there was some variability with the experience level of the nurses that you would work with. And so around 2016, I started to ask questions about what can we do to make this a little bit better, even things like intubations. Some of the more novice nurses were having difficulty feeling really comfortable with it just because of their experience level. And we created a program to do their in situ interdisciplinary simulations at the community hospital site. And it was funded through a grant that the nursing department received to buy a high fidelity simulator. And then the curriculum was developed by me and the nursing staff there. So we started to focus on errors that we'd seen or just patient situations that would cause a lot of stress. Dr. Walsh mentions pediatrics. That's definitely one of them, that when a sick child comes into the community hospital, there's a lot of stress around that. So we tried to get more cases involving pediatrics to give people more experience. Trauma was another one. There's a major trauma center right down the road. So we don't see a ton of trauma at the community center, but there are ambulatory cases that come in. And so we need to be prepared and ready when they do. And so we started to create cases like that. And it's been a successful program. We're going on 12 years. We had a little break during COVID where we weren't running it as successfully. And then now I've handed over the reins to some of the newer physicians that are working in the hospital who are running more of the simulations there. But I thought to myself, what can I say that I learned from running this program? So I'll say that when I started to do this, I don't know if I should admit this, really no experience in simulation. I came to it out of necessity. It seemed like something that needed to happen, and it seemed like there needed to be a better way to do it. So this was my first experience in any kind of simulation education, first of all. So I learned a ton from it, but I'd say two of the most important takeaways that I would give from that experience is that I learned, first of all, the tone of the sessions was extremely important because there were all different levels of learners and people with different areas of expertise, including really experienced nurses that had a lot to offer and add to the simulation sessions. And so it was really important to make sure that there was a tone of growth and fostering a really wonderful interdisciplinary team that was critical for the sessions. And it also interested me, and I learned a lot that I know what I'm worried about when someone comes in who's critically ill. And I think at least I know what other physicians are worried about. Is it going to be a difficult airway? Am I diagnostically on the right track? Am I hitting all the important points? But doing these simulations, I learned that what I'm worried about actually isn't always what the nursing staff or someone else is worried about. It was a really interesting learning experience for me. Sometimes they're worried about setting up the pumps or like very precisely how to accurately administer medications, things like that. And so I'd say that it was important, at least for me, to make sure I had a good interdisciplinary team planning the simulations. We started to invite our pharmacists in to be part of the session so that they could help with teaching about the pumps and things that I really didn't have any expertise in. So those were two really important learning points that I got out of helping with these sessions.
That's wonderful. I think that is such a big pearl that when doing multidisciplinary to have a multidisciplinary team planning it too. Because we just like don't know what we don't know. But yeah.
Yes.
Right.
Yeah.
Perfect. So I'm Jessica Shane. I'm one of the emergency medicine physicians at Mayo Clinic. And my time is split between the academic center in Rochester and then a handful of our community sites in the Mayo Clinic health system. So a little bit of background about our health system. We have 20 or 21 emergency departments that are spread out between Minnesota, Wisconsin, and then we have some clinics in addition to that. And my role is to organize and facilitate in situ simulation experiences throughout all of the health system emergency departments. This program started in 2017, 2018, when there was a push to integrate our care across the health system with the idea that regardless of where a patient presented for care, they would get the same quality level of Mayo Clinic care to the best of our ability, acknowledging, of course, resource differences, but making sure that we were all on the same page, practicing the same emergency medicine with the same goals in mind. And so it was a way to help standardize protocols and procedures and assess how different emergency departments were doing things and make sure that everybody had the same kits available for various procedures and things like that. And then it has taken off and it focuses on multidisciplinary education for those high acuity, low opportunity events, as well as multidisciplinary team training. And then we do some quality and safety things with latent safety threat mitigation and systems integration, particularly as our telemedicine service. In its current form, we get out to probably about 6 or so sites a year. We have a pretty small team that I'm actively working to build, and we rotate throughout the health system. Often we are doing the same curriculum and taking it on the road. And so we'll have one site in that region that we go to, and everybody who works at one of the sites in that region are invited to participate, with the hope that as we grow, we can schedule these a little bit more frequently and a little bit more purposefully. We are still doing an as needed type of education. So the last couple of years has focused pretty heavily on obstetric emergencies because we've had several sites that have closed their on-site OB services. And the Joint Commission updated their safety standards to include role-specific education and didn't explicitly say you have to do simulation, but strongly encouraged that you do simulation. So there's a big push there as well. And then our future goal as we get more, as we grow and we become a more sort of self-sustained thing, would be to include a sort of core curriculum of key topics like trauma, critical care. We've peppered that in as we've gone around, but to get back to it more regularly. And then specifically with our critical access hospital sites to make sure that we are maintaining procedural skills for those folks, because their volumes are low, but we get some sick people that show up to these critical access sites where it's one provider and one nurse and that's it. And so you really have to be on your game, so to speak. So we've done a lot with that specific group of providers on procedural competency and maintenance.
Yeah, I always think it's the hardest to be in those, to be like a critical access. And yeah, that's like the hardest thing in the world.
So excited to be talking with you all. But so I think what I've really enjoyed over the past 2 years is I did emergency medicine residency followed by PEM fellowship. And part of my goal was working on pediatric readiness in general and community EDs, and particularly critical access hospitals. So I did residency in Maine and moonlit in very rural emergency departments. And then during my fellowship, I actually moonlit at a community ED that technically wasn't critical access because it was 19 miles from the nearest ED, but it's an hour away from any children's hospital. And working in that environment, my nurses, I actually still work there because I love it so much, but my nurses there are so talented and they are actually very competent at taking care of them because they see kids don't make it the hour to the children's hospital. Since I started my faculty job about 2.5 years ago, the community ED I work at in our community academic hybrid setting is the 29 bed ED. It's a level 3 trauma center. It has a cath lab, but we don't have OB there. We don't have peds or NICU. And what you'll see is we have at least one delivery a month. We'll see and peds walk-in traumas or burns, or people who just come there instead of going to children's. On the other hand, children's is 3 miles away, so you don't get that familiarity with seeing kids every day that you actually do at the rural hospitals where the kids aren't going to drive an hour to go to the children's hospital. So my role there, so we actually got time for one of our fantastic nurses to be a peds emergency care champion. And she had started working on that about a year before I got there, where she had time to review cases. And because of the deliveries that we were having, she started focusing on doing a quarterly neonatal SIM. And then once I got there, we started working together to say, okay, we've been doing neonatal SIMs every quarter in situ. What else do we need to branch out to? And so some of the things that we've done that I've really enjoyed learning from. So we have done NRP sims. We did a really great burn sim. And for that burn sim, it was actually based on a patient who had come in. And then what we did for that sim was the Children's Hospital actually has a burn liaison that does follow up on burn cases. So she worked on developing a case that we did with a lo-fi mannequin in situ in the community ED. And what was I'm going through learning points for each of those. What was interesting for that one is the doc who happened to be on the day we did the sim was the same doc who had been there for the patient who the case was based on. So we had to work on making sure like this was not a critique of you. Everybody else on this team is different. What we're trying to learn about is like, what are all the steps for a peds burn? Like, how do we do pain medication on a kid you can't get access on? What are the current fluid resuscitation goals? How do we dress our wounds when you're only going 15 minutes away? So it was interesting trying to work with everybody on the team. And what we learned from that was different things that were taken to nurse education days, such as let's review intranasal medications, let's review certain types of access for pediatric patients. Other things that have been really interesting doing are in situ sims every quarter. So we've learned about new equipment that we need to order, like certain high flow nasal cannulas or suction catheters that we do or do not have. We've learned that we had similar equipment in 3 different places and how we could reorganize our pediatric equipment so it was less confusing to people. We've also worked on collaborating with the children's transport team. So we reached out to them and they were willing to come and lend their expertise for when I go to a hospital and see a sick kid, here's what I do to help package them up. And then I think opportunities for collaboration that we didn't realize that existed were we're a level 3 trauma center. Our trauma team has actually wanted to collaborate on some of these sick kids because our surgeons are also really worried that a sick kid is going to show up. Our OR staff and anesthesia is also really worried that a sick kid's going to show up. So I think being able to collaborate with children's burn, the children's transport team trauma has been somewhat unexpected, but has really helped from both a staff education and a systems perspective.
It's very impressive. You're getting the whole hospital involved. That's lovely. So yeah, so let's open it up to questions from the audience. It looks like Tina unmuted.
Yeah, I had a question. I think it's really interesting that you've pulled together all these different stakeholders in creating these pieces of education. So my question is, where did the simulation resources come from? Did it come from the community site? Did it come from one division in the community site? Where did you guys get all this stuff for to do this in with?
I bring mine on the road. My program is run out of the sim center, and so a lot of the sim equipment lives with me, and I have my own beds and equipment and stuff, but I bring it to the site. They have to use their code carts, most of their things, but I bring mock medications and I bring all the simulators. I don't know about other people do.
And how did you purchase the equipment? Did the Sim Center fund it or?
The sim centers have the equipment. At least my sim center does. We have all the different mannequins, task trainers. We actually just bought the PD HAL. So we have a lot of different types of equipment for different programs, different needs.
For our program, most of our support comes from the Simulation Center in Rochester at the academic site. I think we had the luxury of when this initiative to integrate care was launched and this program came into being, the medical director of the Simulation Center at that time was an emergency physician. So it wasn't hard to sell the program or get support that way. So they provide a little bit of FTE for my role. And then I have nurse educator support, sim tech support, IT support. And as of right now, the mannequins and other equipment that we use are from the Sim Center stock. I do have to compete with the Sim Center's calendar for availability of people and things. And I just submitted a proposal to maybe get some of my own things earmarked for me so that we can do this a little bit more frequently. And that was very well received. So hopefully things are coming down the line. But the majority of the resources come from the Simulation Center. And then I'm starting to try to build local health system based faculty so that we can do this independently of my calendar. And so that I build a bench for who I might hand this off to in the future, because I really want to see this program continue to grow and develop. And so at least in the region that I work in clinically, there is a little bit of time built into our clinical FTE for practice building. So it's an incentive to have our team invest in our local practice. And so I'm able to leverage that time to support their efforts as faculty.
I am a low budget operation, so I am shared between children's and the adult side, but on the adult side, you can't take the mannequins out of the sim center. Children's does let you take the mannequins out of the sim center, but if you damage them, it will be thousands. My community hospital trauma has a pediatric mannequin. It's low fidelity that we can use. The ED has a sim baby, and it is completely low fidelity. It's like an NRP mannequin. And then sometimes I will talk with the Children's Sim Center about things I can potentially borrow, like they have burn moulage I was able to borrow for our burn case that, as long as we didn't damage it, it was fine. In terms of like monitoring, I use like the recess monitor. So I'll set up a laptop with the vitals and somebody can control it from a phone. And then in terms of equipment, we do use the ED's expired equipment. One thing we realized originally early on was that our pharmacists own the Broslow bag. So you can't open up the Broslow bag without a pharmacist there. And we started calling a pharmacist to all of these so that folks were able to actually open the Broslow bag, take out the equipment, use the equipment, because that's half the point of this. And finally, like 2 years in, they're like, okay, like we finally made you a training Broslow bag and you can open it and play with it as like whenever you want, which is really nice. And now the nurses are using that. Like the nurses can do it on their nursing education days and everything like that. But we basically say for equipment, our ED is willing to use our own equipment for the quarterly sims, but everything mannequin related is, makeup brush and these two mannequins. And the one time the children's transport team came, they came with a high fidelity simulator, which was awesome.
Yeah, so for our community site, through a grant through nursing, there's a separate simulator that they use. And actually there's another community hospital that's a little more rural that also purchased their own simulator. Our department just got one infant and one adult simulator. So we're going to try to expand some faculty opportunities for simulation as well. And we just put through a grant through our insurer to get additional simulation equipment. So I think that's going to be the next step to expand our simulation opportunities.
I have a follow-up question on it. So it sounds like you guys are getting the resources from different areas. Some of you have established sim center where all you need to do is like, on this day, I need this equipment, it's available for you. And then hearing from Dr. Lincoln that you do have to like applying for grant and reaching out to insurance. Sounds actually very challenging. Like for equipment, I'm hearing like I have to figure out what you're given at your institution and what's available to you. And sounds like you need to collaborate actually outside of EM or outside of like, I guess like the physician group, like a lot of, what I'm hearing is like a lot of nursing groups as well resources. So it's great to hear your collaborators. I also wanted to following up on that is some of you have been doing for many years, but some of you are like, oh, I didn't have much experience and kind of task with this one. So curious to hear what kind of resources or training or any education opportunities that was helpful for you to be where you are right now, especially for people who are not an academic center and who haven't gone to the fellowship training. Like, where do I start? If you could share your pearls, that would be great.
I'll start. I'll jump in. I've been doing this before fellowships existed. So I started simulation back in the early 2000s, like I said, as a mock code program. And then I was formally trained by the Center for Medical Simulation, I think back in 2010, in the very early roots of it, and have done some other faculty development coursework in sim. I don't think you have to do a fellowship. I think you should be formally trained. I'm part of 2 international simulation collaboratives. There are lots of resources between Inspire and the International Pediatric Simulation Society to help with this. I'm also part of the debriefing course, Academy Archives, where we are all online debriefing courses or all asynchronous with videos and other things. There's a wealth of courses out there. There's a wealth of information, and there are varying costs to it. I definitely think you need some formal training. I don't think you can just go and do sim. A lot of people think you just show up and you teach, and there's a lot more to it. I've been doing this 20-something years, but you can find the right course for you. Certainly, we can give Diana some resources to share with the group, but there's a lot out there, a lot.
Yeah, I would echo that. I think for me, I did do a simulation fellowship, and that's actually how I got on the track of community simulation. So when I went into fellowship, my thought process was that I would finish and then I would go be the resident simulation director someplace at some residency program. But in my fellowship, we did a lot of insight to community sims or mock code programs on the floor. And that's really where I decided this has a lot of value with regard to team training and quality and safety and the multidisciplinary aspect. And I really shifted gears. So for me, my fellowship training was invaluable in that it shaped the direction that my career has gone. But in terms of training to be a simulation educator or facilitator, I would agree. I don't think you have to have a fellowship to do that. There are lots of different ways to get that training. Our simulation center hosts a simulation facilitator educator course, and then several sort of additional more advanced pieces of that. You can do an advanced debriefing course after that and things like that. And they're open to everybody nationally. So there's lots of different opportunities to get simulation facilitator experience.
Yeah, when I started, this wasn't obvious to me, but it quickly became obvious to me what Dr. Walsh is saying, that you require some degree of training. So I tried to figure out opportunities and then completed the training through CMS as well, was how I ultimately got a more formal education in simulation. And then strong mentorship, I would say, on top of that.
And I would say it's not something I did during residency, but in fellowship, we had an option. We had a track that they called it specifically Advanced Resuscitation Simulation track, and it was focused on pediatric resuscitation simulation and doing basically setting up an education curriculum for that and developing your scenarios with certain teaching points, and then also how you debrief those in a way that's constructive. But I think the other thing that was really interesting is while I was there, they were building a whole new critical care tower. So they used simulation to find out latent safety threats as they were building this new building and figuring out some of the new patient admission, patient transfer processes. So it was really great to be part of that process for using SIMS specifically for safety and systems and process development. So I think it's something where if you're on the adult side too, if you have a pediatric center that's near you, they may offer simulation facilitator or participation that may not necessarily be there on the adult side, but maybe an additional opportunity.
I'll also just add that in situ simulation is a little bit of a different beast than community-based simulation. There are some other safety considerations that go into it when you're in the clinical environment. And so if your goal is to get into the world of in situ simulation, I would seek out specific training or education on that environment and that setting and specific mentorship within in situ simulation.
And I wanted to follow up on, because I feel like sometimes I personally have done fellowship, but I'm actually curious for people who are, because I definitely had colleagues who like, I'm doing SIM, but sometimes it's like too many resources or it's like too much money. I really love CMS course, but I feel like it's very pricey. So I was just curious to hear, how did you advocate for yourself to get those trainings when you're tasked to do something? Was it your department leader, chair, or did the fund come from outside of your department or grant?
I was funded through my Department of Pediatrics. But again, my training is a lot. I feel like the old person here. Like I trained before fellowships existed in any of this stuff. Like that was when I went and did this, that was really the only thing out there at the time. There's so many more things that you can do cheaper aside from going to the Center for Simulation. And not everybody needs a fellowship. I think they're great, but not everybody needs it. Depends on what your goals and objectives are.
At Mayo, our simulation instructor development course that we offer is free for employees of Mayo. And so there might be other academic institutions that you're affiliated with at your community site or that you partner with that will subsidize some of that training through their simulation centers. I can't speak for every institution, but that is one perk of being at Mayo. But the rest of the training that I've received has either been through various workshops at conferences or through my simulation fellowship.
My CMS training was also funded through my department, so I was fortunate in that way.
I'm sorry, this is a question for Lisa. Did you say you got funding through your insurer? That was really interesting. And that may be some way that's outside of an academic department.
So it's not done yet. We just submitted a grant for funding, but I learned about it through talking to people from other institutions. And then also the Department of OB does a lot of simulations at my institution, and they're funded by the insurer. So they taught me how to do it and to come up with a proposal. So we're insured through MCIC. It's just one of the big insurance groups. And I learned that they give out a certain number of grants every year for actually a fair amount of money. And we put together a proposal. If you identifying a latent safety threat, it seems like would be a fundable thing. We did it for increased faculty development, and we're going to bring it out to some of these community sites as well. I can't remember who said it, but for folks who are at critical access hospitals or some kind of hospital where you don't get to do the procedures all the time, but need to have expertise when they do show up. And so it seems likely that it's going to get funded, but yes, so that is an avenue that other departments at my institution have used to get funding for their simulation programs. And actually it was more simple than I thought. It's very like templated, and you just have to come up with your proposal and submit.
And that's the insurer for the hospital or for the emergency physician group?
It's the insurer.
Maybe it's the same, but it's just interesting. I think
yeah.
They're often the same thing unless it's a private physician group.
That's so cool. I've never heard of that before, of like applying through the insurance.
Back in with me to make sure it works before, but I know other departments have gotten funding that way. Yeah.
It should. Like my program is doing an OB program coming up, and Crico Insurance out of Harvard is paying for the program because it's an OB group. OB and anesthesia have to do a certain number of simulations annually to offset the cost of their medical malpractice. I don't know if it's universal, but it's definitely a New England thing.
It's true where I practice as well. Yeah.
We also have a MCIC insurance like through a safety program, so they have like specific target. But I think OB, it sounds like they really have it well connected with the MCIC funding.
They almost have to be because of the mortality rate in this country. They have to be.
I think there's certainly an art to creating opportunities for academic productivity as like within these quality improvement programs. So I'm just curious to hear from the panel if you've had any roadblocks or success stories about how to disseminate your work or document it well?
Again, I'm the, the elder here. I've published on this. I have an actual paper called Community Mobile in Situ Simulation, bringing simulation to the masses. I've done a podcast with Vic Brazil out of Australia. I published an article about in situ simulation in emergency medicine for risk management. There's definitely places, there are sites I've been going to for 10 years, and I have all the longitudinal data of changes they've made in their system. And every site we go to is always showing us things that they've now changed and done differently. And that's really the paper I need to publish. But you can absolutely publish this work. It's just finding the right journal at the right time who's actually interested.
We have done some work with systems integration from a telemedicine perspective. So one of the ways that we integrate care across our health system and support our lower resourced emergency departments is through telemedicine consultations. So we can consult an emergency physician at the Rochester site. We can consult a stroke neurologist. We can consult a neonatologist. We can consult OB now. And so we can get them on video and have them help manage the patient in real time. And apart from stroke, these other services are all really pretty new, and integrating things like that into your workflow and figuring out who do you activate this for and who do you not, and what can they really do for me to make this useful a part of my practice is challenging. So we incorporate those consultations into our in situ sims so that the people that are working in these smaller hospitals have a chance to interact with the physician this way and understand the value and how to activate the service. So we have a couple of publications on how we were able to integrate that with tele-emergency medicine and tele-OB, and what the provider feedback on that was, what the challenges and barriers were to getting that up and running, and what sort of issues we found as we were implementing this new system across this health system. And then there's a manuscript that I'm currently working on that sort of describes our process for how we set up a simulation and how we debrief at the end of a simulation and what we do with our latent safety threats. And then I've presented at various workshops at IMSH, and I was invited to Ireland for their International Simulation Conference to talk about some of the work that we do with in situ sim and how to get a program up and running and things like that. There are several different ways that you can look at this from a quality perspective. The research project that I have going on right now looks at the patient perspective from a patient safety side. So a lot of the literature that's out there describes how the identification and mitigation of a latent safety threat affects future patient safety. But there isn't a whole lot on how does my presence in the emergency department impact the patient that's getting care in the room right next to me? And does my taking a room out of circulation and potentially using resources that patient might need affect their care? Do people wait longer? Are they leaving more without being seen and things like that? So some of what we're doing right now is tracking a lot of those metrics on days that we're present versus days that we're not, surveying the staff, and then surveying the patients that are in the emergency department at that time to get their perception of being in the emergency department. So hopefully I'll have something to show for that here in a little bit. But we've been collecting data for a couple years because we do this, one, fairly infrequently, and two, in pretty small hospitals. So we might be there for a day of simulation and catch 6 patients. In some of our busier sort of level 2-ish, level 3-ish places, we might catch 15 patients, but to get enough numbers to make a statement, you got to do this a few times.
Thanks so much.
I am aligning with the buy-in and the needs assessment. At least like in my program, it's like a mix of community and academia. And then there have been definitely a little bit of resistance from community sites that are in the Westchester. It's been like they're not used to having simulation getting run frequently and having that educational moments like during their shift. So it was a little bit of, I guess, like shift of like, hey, we do have to do a little bit of continuing education besides from being in a class or going to faculty meetings. I was just curious to hear how you guys were able to assess needs among your faculty group and community sites, and how you're able to link that with the buy-in from the participants, but also from your leadership as well.
Can I also add on top of that, like, how did you figure out how to cover for people's time, especially for nursing time?
So when we do a day of in situ simulation, because we are sometimes traveling 1 or 2 hours away from where we're bringing all of our things and our people, and we're traveling to these sites relatively infrequently on an individual basis. We're there pretty much all day, but that's also a pretty big ask because in some of the smaller sites, we're taking a good chunk of their emergency medicine real estate out of circulation while we're running these simulations. So we do a couple of things. We plan extensively ahead of time for when we think there's the right time to do this. And then we have a backup plan. So we identify a secondary space at the site that's not in situ in case something happens. If there's a bus crash or a bunch of nurses call out sick and now we need to divert resources to the actual emergency department, then we'll do it outside the clinical space, which removes the latent safety threat and systems integration piece to some degree, but still provides us with the opportunity for training and education. So the day is not lost and the effort's not wasted. We also schedule people who are not on clinic duty, not actively working, to participate in the sims, because in some places there's one guy for the whole emergency department. And so we're not going to pull them off of patient care duty to come and participate in a simulation, because if a patient does show up, then they have to go to work. And then the way that we sort of balance attracting participation, one, we've done this enough now, and most people have participated enough now that they see the value in it. So it's not as hard to get people to sign up to come and do it. Two, if we're strategic about how many hours we make these sessions, sometimes the nurses can just get scheduled to come because they have a certain number of education hours or non-face-to-face time kind of stuff that they have to do every month or what have you. So we can make it one of their scheduled days. And then we also offer CME credits for both the nurses and the clinicians that participate. And so oftentimes if you're doing it close to home and it's free CME, people are pretty okay with coming and participating.
I think mine's on the opposite end, since ours are 20, 25 minutes max, including the sim and the debrief. So we've never had to cancel, but I do think if we went in, obviously there were an MCI or something going on, we would just cancel and reschedule for another week. But we have had events where, for example, I think one of the sims, there was a difficult airway that one of the two docs was called to on the floor at the same time as our sim, and we had one doc covering the rest of the ED. I stepped into the role of the doc, and we still had nurses, PCAs, medics doing the rest of the sim. So we would adapt like that based on what the circumstances were. And then we always have a nurse manager at the sims, and we make sure to schedule them several weeks in advance so we can pick a time where there's ideal overlap on the schedule, like usually sometime around shift change. So we'll have some extra folks so people don't feel like they're taking their time away or leaving their patients in an unsafe position to participate in the sim.
I have seen and done the gamut. There are some places we go that we travel by plane and we ship things out, and it's never an issue for those places because it's a very pre-planned event where we're being contracted to come. I do in situ simulation for my own system, but it's very different than my COMET program. And so for my COMET program, I'm more like a contractor, and people are hiring us to come and really evaluate their system and how they are running resuscitation and what are the things that they need to change. We have had, even despite our travel, we have had people cancel because of different system emergencies, and I'm always fine with that. Patient care always comes first. We can always go into a backup room if we need to, but it's not the same as testing your actual trauma room. There are plenty of sites that I go longitudinally where it's mandatory based on what the chair of the department says. We offer CMEs, contact hours, and OEMS credit, which is an incentive, but some of the places mandate it as a safety initiative for their groups. But every place is different. And there are some places where the doctors hate to come, and there are some places where the nurses hate to come. And then there are some places where too many people come. Like, it's just every culture of every place is very different. So you just have to be flexible and roll with it. There's some places I love going, and there are some places where I'm like, God, I hope they never call us again. But just it is what it is.
From a nursing perspective, it's integrated into the mandatory nursing education where I am, and it's voluntary for both APPs and physicians, which is one of the reasons I think the tone of the sessions has been really important for us, because fortunately it's become something that people are excited to participate in. Our APPs ask for more of them. And in my experience, which is limited compared to some other members of this group, certainly, but it's been that if you set a tone where people are excited and they feel like it's worthwhile, we haven't had a lot of issues with having a lot of participation.
And I think it's been really interesting to see some of our attendings or residents really get to show off how good they are at something that they may not see on a daily basis. I think the last peds trauma we did, our nurses were like, wow, like this is amazing. I've never seen, like I knew she was great, but I've never seen this side of this doc. And I think it was really nice to have it not just be, oh, here's all the ways we're going to screw up a peds trauma, but like, hey, these are the things that we did right. And like, this is something that we could handle, even if there's things to learn from.
When you guys are making your cases, and do you guys draw from, like, you're like have like a multidisciplinary team making the case? Do you draw from the people who are working at these different sites, like that type of multidisciplinary, or do you draw from the people at the academic hospital? If you have a nurse or an RT come and write a case with you, is it the nurse RT at your main site, or is it the nurse and RT at the particular hospital you're going to be going to?
So a lot of my cases are based on real patients. And so I've been doing them for so long, a lot of the stuff is in my head and I can change things on the fly if I need to. That being said, for certain programs that are custom and tailored, we ask the site specifically what they're looking for. Are they basing it on a sentinel event? Is there a specific issue that's come up that they want us to test the system? I've done a comprehensive OB, adult, and PD trauma program over 2 days for a particular place, and I asked them, what's your patient population? What are the things that you see? What are your worries? What are your concerns? One of the things that kept coming up, and I said, no, they're like, we'd like a shark bite. And I was just like, no, we're not doing shark bites. Like, so I will draw the line when I'm like, this is silly, but it just really depends. And then I have a lot of nurses in my own site come to me with interesting cases that they would like to see simmed. And then I'll either look them up and work with a bunch of people if it's something that we have to do from scratch. But for me, a lot of it's just I sim on the fly. You tell me what you want and I will just sim it. You just give me the topic. And that's what I do. But again, for places that want a custom program that's very unique, like OB trauma, I have to sit down and think about it with a very big interdisciplinary team because that's not my jam.
I'll say for us, it depends. If we're writing this for a critical access site and they don't have respiratory therapy 24/7, we might talk about how the respiratory therapy piece should be handled from the local respiratory therapist, but also with the people that are going to be receiving this patient on the other end. Like, what would they like to see done before the patient transfers? Similarly with like obstetrics, if the person that we're going to consult for this patient is in Rochester because we don't have on-site OB, then I'm going to work with Rochester. But if it's more likely that this patient is going to be transferred to one of our local smaller medical centers that does have on-site OB, then I'm going to work with them as well to figure out how should this patient present and what should we do. Sometimes, like with obstetrics, the content of the cases or the focus of the cases comes from the Joint Commission mandate in terms of we want to make sure that we're covering postpartum hemorrhage and hypertension. Sometimes it comes from a sentinel event. Sometimes it comes from the provider group. Hey, we collectively don't see this very often and we'd like to practice this again. Or, hey, I had to put in a chest tube last week and it occurred to me that I haven't done that in X period of time. Can we have some more practice on chest tubes or airways or central lines or whatever it is? And so then we fold those procedures into relevant cases as best we can. We have some dialysis centers that are opening up in some of our smaller sites, and there's a lot of questions about these patients in particular, the types of emergencies they might have, bleeding fistulas. So we're working with the medical director of those dialysis centers to put together some relevant education. But I think the biggest trick really is that simulation is wonderful, and I'm very biased, but it is not always the right tool for the job. And so making sure that what you're putting together makes sense and it actually is a multidisciplinary educational tool, because it's really easy for me to write a case that benefits the clinicians, but doesn't really benefit the nurses. And the nurses and the respiratory therapists and the techs or whoever else are involved should not be there as props. They should be there as meaningful participants and should be learning something from this. And so that's, I think, the biggest reason why you want them on your planning team, because if they're not having a meaningful role in this case, then maybe this case needs to be rewritten, or maybe SIM isn't the right thing to disseminate this particular piece of education.
Yeah, I would totally agree on that. So for ours, it's always me and our nurse pack who go through all of the cases together to make sure specifically there is a role for all of the nurses and all of our other staff as well, and not just the doc who may or may not be too busy to come into the sim. And usually where our template is from the beginning is often we'll start with either like the LEM Rescue Sim book or Tele Sim Box or the NRP book as common, like pretty easy basic sim scenarios. And sometimes we'll modify it depending on points that people have asked for additional practice on. We're either starting with those kind of general templates, or we're starting based off of a case or a question that people have. And that may be collaborating, for example, with the burn team at Children's or the trauma team if they had particular things like they wanted to check, okay, can we run our massive transfusion protocol on a kid? How would we do that? Or, for example, working with transport teams, saying like, what points would you want considered for this?
Awesome. Thank you so much. This was such a great panel. I really appreciate all of our panelists and you guys taking the time to do this. Thank you so much.
Thank you for having me.